Good evening, everyone, and welcome to Elevate, a GE Healthcare educational webinar series. My name is Dr. Arlene C. Riodica. I am the Clinical Education and Applications Manager for Life Care Solutions, GE Healthcare in ASEAN, and I will be your moderator this evening. Tonight, we are privileged to have the chair of the Department of Anesthesiology and Intensive Care Medicine in Annunziata Hospital in Chieti, Italy. He is a full professor of anesthesiology and critical care medicine in University of Chieti Pescara in Chieti, Italy. He completed his medical degree at the University of Bari in Bari, Italy, graduating summa cum laude. He finished his specialty in anesthesiology and intensive care medicine at University of Bari, where he graduated summa cum laude. He holds a PhD in respiratory physiology from the University of Paris the 12th in France, where he also graduated summa cum laude. He has won multiple awards for his researches. He holds editorial positions in various publications and holds various positions in different scientific societies. He has been an invited speaker at more than 200 national and international conferences around the world. He is also the editor of the textbook High Flow Nasal Cannula, Physiological Effects and Clinical Applications. Joining us from Italy, let us all welcome Professor Salvatore Maurizio Maggiore to give a presentation on the use of high flow oxygen therapy in COVID-19 patients. Over to you, Professor Maggiore.
Thank you, Arlene. Welcome, everybody. Thank you also for the invitation to talk about the use of high flow oxygen therapy in COVID-19 patients. And we know that COVID-19 very often presents with pneumonia and ARDS in the most severe form, which presents with this radiological feature. You can see the chest X-ray, the CT scan with ground glass opacification, typical of interstitial pneumonia, or in the most severe form also associated with lung consolidation, predominantly in the dorsal lung area. And these images clearly illustrate the lung injury during COVID-19, which is due to different mechanisms, including intrapulmonary shunt, which is the leading cause of severe refractory hypoxemia, which is typical of this disease. Associated with the loss of lung perfusion regulation and intravascular microthrombosis, testifying, of course, the involvement of lung vasculature, not only the alveolar size of the lung. This will lead to impairment respiratory mechanics, dyspnea, tachypnea, and increased respiratory effort and use of accessory respiratory muscle. So it is quite clear to everybody that we should help these patients. We should deliver some form of respiratory support in
Hello, Professor. Hello, Prof. Maggiore.
Can you hear me?
Yes, now we can.
Okay.
We lost
okay.
you a while back.
Okay, so I was saying that there is an additional form of lung injury in these patients, which is associated with spontaneous breathing, and this is the so-called patient self-inflicting lung injury. And this is essentially due to the increase in respiratory drive, together with an increase in lung inhomogeneity due to gravitational forces and regional inflammation. And these will lead to an increase in the inspiratory effort and another phenomenon, which is the so-called occult Pendelluft, which is the shift of gas from the ventral to dorsal lung region at the beginning of inspiration, because the
Sorry,
lung,
Prof.
yes,
We cannot
yes,
see your slides now.
you are not. Oh, I'm
Yes,
sorry. I'm sorry for this.
it's okay.
Um, I don't know if you can see it.
Not yet.
Not. Okay, I will try. I'm sorry. I'm trying to. I'm trying to share the screen again.
Okay, now we can see it.
Okay. So the patient self-inflicted lung injury essentially is due to two phenomena, as I said: an increase in respiratory drive and increase in lung inhomogeneity, which in turn leads to an increase in inspiratory effort and the so-called occult Pendelluft, which is the shift of gas within the lungs from ventral to dorsal region at the beginning of expiration. This in turn will lead to the increase in transpulmonary pressure swing, which is transpulmonary pressure is the pressure which is really applied to the lung, not to the respiratory system, but to the lung, and is the main mediator of lung injury. So this increase in transpulmonary pressure will lead to the increase in tidal volume, which is inhomogeneous. The tidal volume increase, especially, particularly in the dorsal lung region. Therefore, also transpulmonary pressure increase, especially in the dorsal lung region. And this will lead at the end to vol trauma, barotrauma, and athlete trauma, which is really due to the way the patients breathe. So when thinking in giving repair of the lung injury due to the disease and the lung injury due to the patients, to the particularly to the way the patients breathe. So we have different forms of non-invasive respiratory support, in general in hypoxemic respiratory failure, including COVID-19 patients, including nasal flow and the non-invasive ventilation, both in form of CPAP or pressure support ventilation. And non-invasive ventilation may be delivered with different interfaces, including face mask and the helmet. So this is a graph just to summarize, showing a little bit the difference, to summarize the difference between this technique as compared to spontaneous breathing with standard oxygen. As you can see, on the top you have the airway pressure. Yeah, you can see the gas flow. And as you can see, with nasal flow, we increase a little bit the pressure within the airway, especially during expiration. And with CPAP, we are doing essentially the same, but we set a single level of pressure. This is not set. This level of pressure is not set. Actually, we set the flow, and the expiratory pressure is increased. And then with CPAP, we set a single level of pressure, which is maintained theoretically during the whole respiratory cycle, single level of pressure. And with the true non-invasive ventilation, at two levels of pressure, we set two pressure. The expiratory pressure and the inspiratory pressure, which is reached during expiration. You can see this rise in pressure during expiration. And this form of non-invasive ventilation with two levels of pressure is the form of non-invasive ventilation who give the greater support to respiratory muscle, so it may decrease the inspiratory effort the most. First of all, concerning nasal flow, what are the physiological effects? We know that this technique allows to deliver high gas flow to the patients up to 70 liters per minute. This gas is fully humidified. And when we apply this gas flow, which is typically delivered through a nasal cannula, therefore applied to the nose of the patients, we can increase, as I said, airway pressure. And this increase in airway pressure may recruit the lung, may increase lung volume, may increase lung compliance, and may participate to increase oxygenation, which is also due to the delivery of higher and more stable level of FiO2 as compared to standard oxygen. Delivering high gas flow may also have another important effect, which is the washout of upper airway dead space, which may improve the CO2 clearance. And of course, we deliver adequate humidity to the airway. All these effects may decrease the work of breathing, decrease the respiratory rate, respiratory drive, and finally improve patient comfort. So this technique for all these physiological effects has been used in different contexts. And the most interesting and what we are more interested concerning the issue of this webinar is the use in hypoxemic patients in hypoxemic respiratory failure. And beside COVID-19, this technique has been used in patients with hypoxemic respiratory failure. We show you the results of probably the most known study on this issue, which is the study by Jean-Pierre Hfot, published in 2015 on in the New England Journal of Medicine. And in this multicenter randomized control trial, authors randomized almost 300 patients with hypoxemic respiratory failure, PaO2 ratio below 300, to receive oxygen alone, nasal flow alone, or NIV. NIV was delivered intermittently. Therefore, there were different NIV trial.
Hello, Prof. We are losing you.
In between high flow and non-difference in terms of intubation between these two groups, even if there was an advantage, a slight advantage for the high flow. But the reason why this study is known everywhere is that a little bit surprisingly, the use of survival as compared both to standard oxygen and non-invasive ventilation. And with the nasal flow, there was also lower dyspnea, lower discomfort, lower respiratory rate, and better oxygenation with respect to the other technique. Well, other studies in hypoxemic respiratory failure has been performed, and of course, meta-analysis on this trial has been performed, 9 trials in particular, with more than 2,000 patients with hypoxemic respiratory failure. And this meta-analysis look at the effect of nasal flow as compared to standard oxygen on different outcomes, and there was no difference in terms of mortality. But with nasal flow, there was a significant reduction for the need of invasive mechanical ventilation. That is, there was a significant reduction in the intubation rate. And based on this meta-analysis, other meta-analysis, recently a clinical practice guideline have been released last year. And in this meta-analysis, of course, we take into the consideration the results of this meta-analysis, and concerning patients with hypoxemic respiratory failure, based on the results of the meta-analysis I've shown you before, we recommended, and this was a strong recommendation, using high flow nasal cannula as compared to standard oxygen for patients with hypoxemic respiratory failure. And the level of evidence was moderate. And again, this was a strong recommendation. Well, in this guideline, we said okay, this should be true also for hypoxemic patients due to COVID-19. And in fact, several guidelines were published during the pandemic concerning the use of non-invasive respiratory support in these patients. And you can see here different guidelines and with different technique, nasal flow, CPAP, or B11 non-invasive ventilation. And these guidelines everywhere in the world more or less supported the use of nasal flow, even if recommendations were weak or conditional, because the level of evidence specifically with COVID-19, especially at the beginning of the pandemic, it was not so strong. But you can see also that actually there was a support for every form of non-invasive respiratory support technique. And this would reflected the fact that we actually had a big problem for managing many patients at the same time. So the concept was try to use whatever you are is better than standard oxygen. But with nasal flow, we had really the support of the data I showed you before, which give you support to use again nasal flow in patients with hypoxemic respiratory failure. Of course, this technique does not work for every patient. For example, we have studies like this. This is a retrospective small study coming from China, who look at the rate of nasal flow failure in patients with COVID-19. And as you can see, the failure rate was much higher with nasal flow in the most severe patients, those with a Q2-FeO2 ratio below 200. Therefore, the more hypoxemic, the more severe patients are exposed to the risk, a greater risk of nasal flow failure as compared to the less severe, those less hypoxemic. And the same is true on the available clinical practice guideline based on meta-analysis that actually non-invasive ventilation as compared to standard oxygen does not confer any benefit in terms of mortality. And this is because results on the use of non-invasive ventilation in this context has led to conflicting results. Some study shows that in some patients, hypoxemic patients, NAV may be useful. In some other shows that actually
Hi, Prof. Okay, let us just wait for Professor Maggiore to log in again. I think he dropped out. Sorry about that. Professor is having some internet issues. Hi, Professor. You are on mute. We cannot hear you.
okay, now can you hear me?
Yes.
I'm very sorry. I don't know what's happening. The network it seems does not work very well. In any case, I'm trying to. Can you see my slides?
Not yet.
Not yet. Okay. So I'm trying to sharing again my screen.
Okay, we can see it now.
Okay. Yes, but sorry, I have to reopen the file because it was. Okay, can you see it?
Yes, we can
Okay,
see it.
you see the presentation? Okay.
Yes.
Okay, I was saying so that also the use of NAV in patients with hypoxemic respiratory failure is debated, and the current guideline does not offer any recommendation, specific recommendation in this. And we know that use NAV may be useful in some patients and dangerous in others. For example, the results of this post-hoc analysis of a large observational study in patients with ARDS, with hypoxemic respiratory failure, shows that as compared to invasive ventilation outcome, the survival was similar between patients treated those with a Q2-FeO2 ratio below 150. In these patients, use of non-invasive ventilation was associated with a lower survival, so a worsened outcome. So this data show both for a nasal flow and for non-invasive ventilation that's been
Hello, Prof. We lost you again. Let's just wait for Professor Maggiore to log in again. Very sorry about that.
I'm very sorry for this. I'm trying to change the network. I don't know if you can hear me now.
Yes, loud and clear.
Okay, let's see if this time could be better. For both nasal flow and AV, probably the safety of this technique may be lower for the most severe patients. Unfortunately, Patients with COVID-19 very often presents with very severe oxygenation impairment, at least those who are treated in the ICU or treated by intensivists. So what about non-invasive ventilation? We know that non-invasive ventilation may be applied, as I said, with face mask, helmet non-invasive ventilation. Helmet is an interface which is less used. However, there are interesting results concerning this way to deliver non-invasive ventilation. For example, this study by Bhakti Patel published in JAMA 2016. In this study, the authors compare in patients with severe hypoxemic respiratory failure the use of non-invasive ventilation with face mask or with helmet. And what they found is that when NIV was delivered with helmet, the intubation rate was decreased, so less need to intubate the patients, and also survival was improved. So clearly an impressive improvement in outcome. And when we look at what are the difference of delivering NIV with these two interfaces, we see that probably the most striking difference is the level of PEEP, which is significantly higher with the helmet than with face mask. And the problem is due to patients' tolerance and air leak, because when they tried to increase PEEP with the face mask, this was not possible exactly for this reason: excessive air leak or patients' intolerance. So helmet may be more comfortable, may predispose to less air leak, therefore may allow to apply higher level of PEEP, and also probably for more time continuously, because the interface is more tolerated by the patients. The problem of applying the higher level of PEEP is important, because applying higher level of PEEP when the patient is breathing spontaneously may have a protective effect. This, for example, has been shown in this study, both in animals and in patients, in which authors compare in patients or animals with hypoxemic respiratory failure use of low PEEP or use of high PEEP. And both in animals and in patients, use of high PEEP was associated with less esophageal pressure swing. This was true also in patients. Less esophageal pressure swing means that the intensity of inspiratory effort was decreased. So using a higher PEEP may decrease the intensity of inspiratory effort, therefore may induce less injury to the lung. And this was also suggested by the decreased inflammation that you can see with low PEEP here in the caudal and dorsal region of the lung. Again, when low PEEP was applied, and this inflammation, this is a PET-CT scan, which is illustrated here by these yellow areas, disappear when high PEEP is applied. So less effort, less inflammation, less injury. And in fact, as you can see, these are true recording from the same patients breathing standard oxygen, high flow, CPAP, or helmet NAB. And you can see here esophageal pressure swing, and the amplitude of this swing is proportional to the intensity of inspiratory effort. You can see that with helmet, the intensity of this effort is lower as compared to standard breathing, and also as compared to nasal flow. And this is the transpulmonary pressure, which is the mediator, as I said, of lung injury, which is greater with standard oxygen, less with nasal flow, and even less with helmet NIV. Now, what was the starting point last year at the beginning of the pandemic? We know from the results of this meta-analysis, we knew that the use of any form of non-invasive respiratory support may be useful in hypoxemic patients, with difference in between among techniques. But what was clear from this meta-analysis is that there was no comparison between high flow nasal oxygen and helmet NAV, which are, as I show you, the most promising technique to be used in these patients. And for this reason, together with Domenico Grieco in Rome, we first performed the physiological study to compare helmet NAV and nasal flow in patients with severe hypoxemic respiratory failure, just to assess what are the physiological effects of these two techniques compared together. And what we found is that with the helmet non-invasive ventilation, we had an improved oxygenation as compared to nasal flow, and no difference in terms of PCO2, lower inspiratory effort, lower respiratory rates, lower dyspnea, while the transpulmonary pressure was not different. And interestingly, what we found is that the most severe patients, those who exhibited the stronger effort with nasal flow, had the greatest reduction in transpulmonary pressure and in intensity of inspiratory effort when shifting with helmet non-invasive ventilation. Therefore, the conclusion of this study was that helmet NAV can be more effective than nasal flow in patients with moderate to severe hypoxemic respiratory failure, particularly in the most severe patients, like those more hypoxemic and those showing a more vigorous inspiratory effort. And based on the results of this study, we designed, performed, and published in March, a few months ago in JAMA, this study, which was a multicenter randomized controlled trial comparing nasal flow and helmet in patients with hypoxemic respiratory failure due to COVID-19. This was a study performed in Italy. We plan to enroll patients with moderate to severe respiratory failure, PA2 below 200. Actually, we enrolled even more severe patients because the average PA2 was 100. We enrolled 110 patients, almost randomized to receive helmet non-invasive ventilation or high flow. And helmet was applied continuously for 48 hours, and then we tried to wean helmet non-invasive ventilation to nasal flow. And the primary outcome was the number of days free of any form of respiratory support within 28 days. And when with any form of respiratory support, we included both nasal flow, any form of non-invasive ventilation, and also invasive mechanical ventilation, so also intubation. This was the setting of helmet non-invasive ventilation, and which was delivered with a ventilator with an average PEEP of 10 to 12 centimeter water, so quite high, pressure support 10 to 20 to 12, and FiO2 titrated to SpO2 to reach an SpO2 target between 94 and 98. Of course, patients were continuously monitored, and this is the primary outcome. As you can see here, there was no difference between helmet NAV and high flow oxygen in terms of median respiratory support 3 days. This difference, 20 versus 18, was not significant. However, with helmet, we found a significant decrease in the intubation rate from 50% with nasal flow to 30% with helmet non-invasive ventilation. And this was a pre-specified secondary outcome based on predefined criteria, and particularly less patients were intubated because of hypoxemia with helmets, respiratory muscle fatigue, or dyspnea. And also, with helmet, we had significantly less invasive ventilation 3 days. Therefore, in general, there was no difference in terms of days free of any form of respiratory support between nasal flow and helmet NAV, but there was less patients intubated with nasal flow. We tried also to characterize what kind of patients may benefit more from helmet non-invasive ventilation as compared to nasal flow. And the idea for us was that probably the most severe patients could benefit more from helmet as compared to nasal flow. And we proposed this index to assess the patient severity, which was not only based on the PO2-VO2 ratio, but also on the degree of dyspnea as assessed on the visual analog scale. And so we proposed this oxygenation to dyspnea score, which is the PO2-VO2 ratio divided dyspnea. And the idea is that the greater this index, the less severe is the patient's, while the most severe patient has a lower value of this score. And we look at the intubation rate in patients who were less severe, those with this index greater than 30, and in the most severe, those with an oxygenation to dyspnea score lower than 30. And for the less severe, as you can see, there was no difference in terms of intubation between nasal flow and helmet NAV, while for the most severe, both in terms of oxygenation and dyspnea, we confirm the major protective effect in terms of intubation from helmet NAV. Of course, when using nasal flow, there was a concern, especially at the beginning of the pandemic, about the risk of environmental contamination with nasal flow. And this study, for example, where specimen of environment of an isolated room where nasal flow was used demonstrated that there was an environmental contamination and therefore nasal flow may have this risk. However, several other studies have, like this one, have demonstrated that the use of a simple face mask above the face of the patients, so above the nasal flow, is sufficient to significantly reduce the aerosol generated by the nasal flow at level which are compared with non-invasive ventilation or even less. This was confirmed by other studies. So the use of face mask is actually, of course, recommended together with the use of adequate PPA from healthcare workers. So the take-home message from my presentation are the two techniques, nasal flow and continuous IP helmet NAV, are probably the preferable technique for non-invasive treatment of patients with hypoxemic respiratory failure. And helmet NAV may be, by using IPEEP, may be probably more interesting in the most severe patients. And in any case, what is extremely important is to careful monitoring patients in order not to delay intubation and invasive ventilation, because we know that delaying intubation may worsen patients' outcome, actually is associated with an increased patient's mortality. And from a practical standpoint, what can we use to monitor patients under nasal flow? What has been proposed is to use the so-called ROX index, which is the ratio of SpO2 to FO2 divided respiratory rate. And when this index is greater than 4.88, this is associated with the success of the technique. So we can continue to use nasal flow and continue to monitor patients. While this index is low, below 2.85, this means that the patient is not going well and that we should consider to intubate the patient. So the use of ROX index is a simple way to monitor patients even in the world, because this is essentially a non-invasive way to monitor patients. And of course, we should also consider the criteria for intubation, which are listed here. These are the common criteria for intubation. What I would like to say, to focus your attention to the fact that intubation is not only based on number coming from monitors or arterial gases, blood gases, but is also based on the clinical observation of the patients for the presence of dyspnea, for sign respiratory muscle fatigue, from for tolerance to the use device. So again, please monitor your patients on any form of non-invasive respiratory support. Thank you very much for your attention.
Thank you very much, Professor Maggiore. So we are now open for questions. Please type in your questions. Professor, I have one question. Yeah. While you are doing high flow oxygen therapy, are you also putting your patients on prone position?
We have patients who respond to nasal flow and prone position. With nasal flow, of course, the use of prone position in patients which are awake and spontaneous breathing is much easier, for example, as compared to any form of non-invasive ventilation, including helmet and AV. So this could be an advantage of a high flow. And in fact, for example, in our study, many patients who were randomized to use high flow nasal oxygen were put on prone position. Some patients answer, this is the response in terms of oxygenation lasts for sometimes, for other patients less. Actually, we have report showing that there is a potential interest of this maneuver, but what we lack actually is a definitive randomized control trial on this issue. So for now, we have only observational report. But we know that there are randomized control trial ongoing, and results of this trial will inform clinical decision in the future. But this
is an
option. However, is a useful option.
Okay, all right. We have a question here. If the FiO2 is more than 0.6, do you already intubate your patient, or will you put your patients on NIV trial
sorry,
first?
can you say it again? Which parameters?
If the FiO2 is 0.6, do you intubate the patients already, or do you still try?
You mean 0.6 with the nasal flow?
I think on standard oxygen. So the question is, will you change to NIV first, NIV trial, or intubate?
No.
On high flow.
On high flow, okay. On high flow, this is more logical because, of course, with oxygen, almost all these patients that we have seen, we intensivists have seen, have need a FiO2 greater than 0.6 under standard oxygen. With nasal flow, I will, without any doubts, increase oxygen. If these patients needs, unfortunately, a lot of oxygen. So I will not limit the use of nasal flow to the FiO2 of no more than 60%. So we have used in these patients many times a FiO2 well above 60%, 90 and even 100%. The problem is looking at how the patient is going. If even after under 100%, the patient is doing well, the oxygenation is satisfactory, and the patient has no dyspnea, the patient has no sign of excessive respiratory muscle effort. This is extremely important. So I will continue to use nasal flow. However, if there are any signs that I have shown you at the end of my presentation, so dyspnea, intolerance, very severe hypoxemia which is not corrected, or hypercapnia, so in this case I will not lose time, I will go directly to intubation. But I have used many times nasal flow even with 100% oxygen. Of course, these are patients who need even more strict observation as compared to the other. For example, if you have free bed in the ICU, I would prefer to take these patients from the ward to the ICU, or even in the ward to observe, to monitor these patients a little more strictly as compared to patients who need less FiO2.
Thank you very much. We have a lot of questions here. What
I'm
is the
available.
initial what is the initial high flow nasal cannula setting, and what will be the initial flow rate that we should set?
Okay, there are essentially three settings with nasal flow, which is FiO2, flow, gas flow, and temperature. I will leave FiO2 at the end. First of all, I will start with gas flow. Usually, we know that many effects of the nasal flow, many physiological nasal flow are dependent by the level of flow, which means that increasing flow, we increase the pressure we generate inside the airway, we increase the upper airway dead space washout, we increase the FiO2, we increase many things. So when I start OptiFlow, usually, especially in this patient, I will start with the maximum flow, so 60 liters per minute. And then concerning temperature, I will start with 37 degrees, the highest, in order to give the full humidity. But then I will ask to the patients, first of all, if there is discomfort with the temperature. Some patient will say, no, there is too hot, it's too warm. So I will not hesitate to decrease temperature based on patient comfort. And also the gas flow should take into consideration patient comforts. Therefore, if the patient will say, doctor, I have too much air, too much flow inside the nose, I will try to decrease a little bit, but keeping the maximum high flow which is tolerated by the patient. In general, I have never seen patients, at least the COVID-19 patient with a severe hypoxemia needing a nasal flow, who will complain because the gas flow is too high. So all the patients I have treated, and also by sharing this with other colleagues, there was no complaint as concerning the flow. So 60 liter gas flow, temperature as high, the highest which is tolerated by the patient, and FiO2 at the end, the minimum to reach the SpO2 target. I remember that the oxygenation target in terms of SpO2, especially for these patients, could be between easily between 92 and 96. So we do not need to have 100%, 98, 99% of oxygen. Instead, exactly this pandemic has clearly demonstrated that even some form of hypoxemia could be well tolerated by patients. We have talking about epi or silent hypoxemia, if you remember, and this clearly demonstrated that a moderate hypoxemia is well tolerated by the patient. So FiO2 to reach 92, 96 oxygenation target of SpO2.
Okay, further to the two questions, there are two more from the same person. What is the complication when we use high flow oxygen therapy? And when can we say that HFOT has failed?
Concerning the complication, honestly, I've not seen any complication. from this technique since many years of use. The only complication, which is not directly related to the technique, may be the delay in intubation. If we use nasal flow just to have a cosmetic, but without a real improvement by the patient, this may delay intubation, and this may be clearly dangerous. Concerning when we say that nasal flow has failed, I have suggested that there are no clear parameters to say this. So we should go to the clinical observation, so sign of dyspnea, excessive respiratory effort, muscle effort, tolerance, arterial blood gases, other vital parameters, and in particular, particularly, of course, I would like to focus the attention on oxygenation and respiratory rate. And these two parameters are summarized in the ROX index. If using nasal flow, the oxygenation is not improving and respiratory rate is not decreasing, because we have many publications showing that one of the early effects of the nasal flow is to decrease respiratory rate. If we are applying nasal flow, respiratory rate is not going down and oxygenation is not going up, therefore the ROX index will be low. So in this case, do not hesitate to escalate for treatment, which can also means doing a trial of non-invasive ventilation, for example, with helmet, if you have it, or go directly to invasive mechanical ventilation, because the most important is not oxygenation in these patients. We have seen many patients also coming from home with pneumothorax, barotrauma, and these clearly illustrate the risk of what I talked about, the patient's self-inflicted lung injury. So the way the patient's breath can be dangerous from the patient itself. So in this case, the only way to solve this patient, if other technique does not work, is to intubate patients, paralyze the patients, make 48 hours of protective mechanical ventilation, and then reevaluate.
Okay, thank you. How many hours will you wait before you say that I need to intubate? So let's say SpO2 is not improving, the respiration rate is not coming down. How many hours will you wait before you say that?
1 to 2 hours, not more. No
Okay.
more than this. Yeah.
Okay. Can we use high flow oxygen therapy for neonates and pediatric patients? And
Yes,
if
of course.
yes, at what
Yes.
setting? At what flow for pediatric and neonates?
Please, so consider that nasal flow has been introduced first for pediatric patients and then for adults. So in pediatricians should know, at least pediatric intensivists should probably know this technique before adult intensivists. And also in infants, this has been used at the dose in terms of flow of 1 liter per kilo of body weight. And of course, it depends by the age. Let's say patients who are 15, 16, 17-year-olds are more close to adults, of course. So in the smaller, in the younger children, the dose of flow is approximately 0.5 to 1 liter per kilogram of body weight.
Okay, thank you very much.
You're welcome.
We have one question here regarding aerosolization. For high flow nasal cannula with flow of more than 35%, is it already considered aerosolized?
So if I understand correctly, the question is that if the risk of aerosolization is greater when the gas flow is greater than 35 liters per minute. Is it correct?
At 35% high flow nasal cannula, will it be considered aerosolization already?
There is something which I do not understand, because if you say 35%, I would think about FeO2, but the risk of aerosolization is not due to the FeO2, but it will increase with increasing the gas flow. Therefore, if you have 60 liters per minute at 21% of FeO2, the risk should be greater than 100% FeO2 with 20 liters per minute. I don't know if I'm clear enough. So the risk of aerosolization is linked to the gas flow, not the FeO2. But in any case, even if with the highest level of gas flow, just putting a face mask on the face of the patients on the device is largely sufficient to greatly decrease the risk of contamination. Of course, we should approach these patients with the adequate PPE, the gloves, and whatever.
Mm-hmm. Okay, thank you very much.
I would add, because I'm seeing that there is a question concerning the risk for healthcare worker and the aerosolization with nasal flow, and this was also the concern we had during the first wave of the pandemic last year here in Italy, and we said, okay, we should be cautious also as Italian Society of Anesthesists to recommend nasal flow as first line treatment, because there is a risk of aerosolization. But at the very end, the data coming from the environmental risk, showing that the environmental risk with the face mask on the patient is very low. And with this precaution, plus the use of adequate PPE, many other studies also performed in Italy have shown that the risk for healthcare workers is not more important as compared to NIV or even invasive mechanical ventilation. So I would say that with simple measure, use of adequate PPE again, and use of face mask on the patient's face upon the device, the risk for healthcare workers is really negligible.
Thank you. That's very nice to hear. Assuming that the patient,
this is very important.
Assuming that the patient improved with high flow nasal cannula, how do we titrate in patients who are improving? How do we titrate down on the settings?
Yeah, this is concern. So the question concern the weaning of nasal flow, actually. So first of all, we start by decreasing FeO2. So this depends on the level of FeO2 and gas flow we are using. Let's imagine we are going at the maximum. For example, for 100% FeO2 is 60 liters per minute, okay? So in this condition, I will start to decrease FeO2, 100%, 90, 80, 70. When I will reach 60%, below 60, then I will start to consider also to decrease gas flow from 60 to 50. So I would decrease the FeO2 first. Below 60, I would say also below 50%. When I will reach an FeO2 below 50%, then I would start to decrease a little bit the gas flow, 60 to 50 or 40. And if the patients will tolerate this small decrease, I will put the gas flow directly to 10 liters per minute, very low. So in other terms, I will stop the high flow. I will convert to the standard oxygenation device flow, 10 liters per minute, to see if the patients tolerate this or not. So first decrease FiO2. When you are below, let's say 50%, start to decrease 60 to 50 liter per minute gas flow. And if the patients tolerate, probably the most interesting could be just to go directly from 50 to 10 or even 60 to 10 to see how the patients react. If the patient is not tolerating, in any case, he will show you very soon. So you stay there and you see very quickly, then the oxygenation will drop down and respiratory rate will increase. So you need to increase the flow. So first the FiO2 and then the gas flow.
Okay, thank you very much. Professor, how do you select the size of the nasal prong for HFOT?
Yes, in theory, the nasal prong should be adapted, of course, to the size of the nails. And the idea is to occupy at least half of the caliber of the nails. In practice, really, we use in 90% of cases, the medium size.
Okay, medium.
There is an important effect, because if we decrease the size for the same nerves, if we use a small size, so we have a greater leak. In this case, the generation of pressure is lower, so the PIP effect is lower, but we will increase the washout of upper airway and the CO2 elimination. If we use on the nerves a greater prong, then the washout can be lower and the PIP effect can be higher. Therefore, in hypoxemic patients, it is important to use, let's say, larger size, M or L, medium or large. In COPD, or in patients who are hypercapnic, probably could be more important to use smaller in order to increase leak, dead space, washout, and CO2 elimination.
Okay.
So in general, we use medium size.
Okay. There's an interesting question. Can we use CPAP on top of high flow nasal cannula? For example, okay.
It has been used. We have published. There is a couple of case reporting the use of nasal flow with CPAP, but this has been done with CPAP delivered with helmets. So, okay, because of course, if you put the nasal cannula and then you put the mask, with the mask you can compress the high flow, the nasal high flow circuit, and this can also be more uncomfortable for patients. While if you use the helmet, you have nasal flow and the helmet inside with two circuits. This has been used, and what has been shown is that you can combine actually the effect of having higher pressure, because with CPAP you can deliver higher pressure than the pressure that you can usually deliver with simple nasal flow. But also you can have a quite efficient washout of airway dead space. So you can combine a little bit the effects, and this could be interesting if at all feasible. But this has been done particularly with the helmet CPAP, not with the face mask CPAP.
Okay, thank you. Have you ever experienced patient developing bleeding with a high flow nasal cannula?
Really sporadic case. No, I personally, I have never seen any single patients bleeding because nasal flow. Of course, my experience can be limited, but when we look at the trials of the study on nasal flow, really this complication is really anecdotic, really very, very rare. So I would say that this is really not a problem.
Okay. Do you bring down the temperature of the humidification, or you leave it at 37 degrees?
Yes, as I said, we have data. We should publish this study where we measure comfort with different settings in terms of gas flow and temperature. And as concerning temperature, we have seen that in some cases, use of high temperature can worsen patient comfort. Therefore, the answer, as I said before, is yes. If the patient is tell me that the hair is too hot, it's too warm, I will decrease temperature to 34 and even to 31 if this is needed. You should consider that for this technique, it is extremely important the patient's comfort. Okay, so we should maximize patient comfort because patient comfort is important for the success of the technique. Of course, this also depends based on the patient severity, but it is important to try to optimize the patient's comfort. So if patients complain because the temperature is too high, I will decrease temperature to 34 and even 31. Patients' comfort depend on gas temperature and also on the level of gas flow. Some patients complain that gas flow is too high. In general, those patients who complain for discomfort because the gas flow is too high are also the patients who are less severe. In general, patients who are more severe tolerate the highest gas flow much better. And of course, gas temperature will depend also on gas flow. If the gas flow is highest, I will start with 37. But if I have 30 liters per minute, for example, sometimes I will start even directly with 34 degrees, so a little bit smaller. The question, the direct answer to your question is yes, I decrease temperature if the patients complain about this.
Thank you very much. I think we only have time for one last question, but there are still so many questions here. In case patients are undergoing hemodialysis, should we adjust any setting in the high flow oxygen? Do we adjust the flow? Do we adjust the FiO2?
No. I will do exactly as all the other patients.
Okay. Thank you very much. I think that will be the last question for tonight. Thank you very much, Professor Maggiore.
Okay. You're welcome. It was my pleasure. I hope the webinar has been interesting. And if there are some odd questions, I'm still available to answer by email.
Okay. I will send you the questions, Professor.
Okay.
Thank you so much for sharing your
Bye.
expertise. Bye-bye.
It's my pleasure. Thank you. Bye.
Bye-bye.